Okay. One thing that I was talking about yesterday is when we talk about the inhalant agents is the chemical properties, and it is a way to compare agents. And one of the properties of inhalants is their vapor pressure, which is the likelihood that the liquid will turn into a vapor or a gas. And um, how readily they do that. And, I started to talk about this yesterday because I was talking about temperature. Temperature can affect vapor pressure. So typically, the vaporizer that is used does have a temperature control mechanism to try and help set the temperature at a controlled state, which will help it vaporize at a controlled state. So when you have a volatile agent, that is an agent that has a high vapor pressure. Isoflurane, SIBO, and halothane. Remember, I'm not talking about desflurane. Those were all agents that had a very, compared to like ether and compared to methoxyflurane, when they developed halothane, then iso, then SIBO, is there was a very high vapor pressure, and they have to have a precision vaporizer. What that means is, okay, so there's two types of vaporizers. There's precision, then I'm going to talk about a non-precision. So a non-precise vaporizer, you don't have as much control, but if you want to be precise in the amount of agent that you deliver, you have to use a precision vaporizer. And that has to be used with agents that have high vapor pressures. And then I told you yesterday, those agents have different vapor pressures. I'm not going to make you memorize the vapor pressure of the three agents. I just want you to know halothane, SIBO, and iso have high vapor pressure. They need a precision vaporizer. And they are specific. You cannot interchange the agents with the vaporizers. And you, like I said, if you do that by accident, you have to tell somebody. Because again, it can be very dangerous. You do have to clean it. People make mistakes. If somebody was willing to fire you because you put something wrong in the vaporizer, that's not somebody I would want to work for anyway. So I don't want you to be worried about that. You just have to say something. Now, methoxyflurane, which was one that I did say I was going to cover, that was a low vapor pressure, meaning methoxyflurane doesn't easily become a vapor, and therefore you could use the non-precision vaporizer. So it's considered non-volatile. Think about volatile. It's like, if you're volatile, like, I don't know what's going to happen. With a high vapor pressure, if you deliver it like on a cotton ball, in a jar, in a mask, you don't have control. It's very volatile, wants to become a gas. So non-precision vaporizers. Now, for example, there's some notes under here, but for example, isoflurane, the max I can deliver on the vaporizer is 5%. Halothane was also 5%. Now I'm going to get into sevoflurane, goes up to 8%, an 8% setting. So because it's a different agent. But you can see, remember I said if it was on a cotton ball, isoflurane could be up to 30%. And the max I'm telling you we deliver is 5. So that's because it's volatile. It has a very high vapor pressure. Now, something that we talk about, and this is a little bit harder to understand, is the blood gas partition coefficient. It's basically what I want you to know. This is the blood gas solubility of an agent. So blood gas solubility and blood gas partition coefficient are the same thing. They're talking about the same thing. But how it measures the solubility of an agent compared to alveolar air. What this tells me about an agent is how quick can I induce them and recover them, okay? And I'm gonna explain how this works. So an ideal agent, is going to have what's called a low blood gas solubility or low blood gas coefficient. What that means, now think about solubility or like dissolving. Okay, isoflurane has a very low blood gas solubility. So what happens When an animal inhales isoflurane, okay, it goes into the alveoli and then it's going to diffuse into the blood. Now, when it goes into the blood, it has a very low solubility, meaning it doesn't start to dissolve. I think about solubility, dissolvability. So think about it. If the molecule of isoflurane goes in the blood and it remains intact, when it gets to the brain, there are more intact molecules hitting the brain, meaning they're going to go to sleep very quickly. So when you have an agent that has a less or low solubility in the blood, you get a quick induction and quick recovery. You achieve anesthesia quickly and recover quickly. Now, if I talk about agents that have a high blood gas solubility, that would be like halothane and methoxyfluorine. Those agents are more soluble in the blood than in the gas. And so what happens is when it gets into the blood, some of it gets absorbed in the tissues. It kind of, think of it this way, it kind of starts to break down, solubilize, dissolve. Well, what happens if the tissues absorb some halothane and it starts to dissolve? By the time it gets to the brain, you don't have everything they inhaled. The tissues took some, the plastic takes some, the blood has some. And so what happens is when the blood gets to the brain, you don't have all that agent, and it takes longer to induce them, and it takes longer for them to recover. So an ideal anesthetic agent, if you were going to make the ideal inhalant, you would want one that has a low blood gas solubility, right? Because then once it hits the blood, it stays in the blood. It doesn't break down in the blood. It doesn't start to move into the tissues. It doesn't get absorbed in the plastics. So therefore, by the time the blood gets to the brain, you have intact drug. You have higher amounts that reach the brain, if that makes sense. So when you compare the agents, and think of it this way, and again, this is an application, so this is perfect for like the test, is that, okay, if the blood gas partition coefficient, it kind of helps us determine which agent we're going to use. So induction, can a mask be used? Well, I'm going to tell you, I've not talked about masking a patient, but when you put a mask on a patient and they have to hold that mask on their face and they have to breathe in the gas, would I want to use an agent with a low solubility or a high solubility if I was going to mask a patient?
Probably low, so it wouldn't take as long for them to fall asleep because you're holding that mask on.
Amen. You want to spend as little time as possible. And yeah, you want a low solubility because, right, if I want something that's going to be a quick induction. So the lower the blood gas solubility, the faster they're induced. Now for maintenance is, I told you guys in surgery, you'll put them on a percent and then I have you turn them up and down kind of based on the clinical signs or their vital signs. But if I don't like where my patient is, if I don't like their heart rate and their breathing, and I want to make changes to my patient, do I want an agent with a high or a low solubility? Which one do I want to pick? I want to be able to make rapid changes to my patient. Say I have like a critical patient. Would I choose the high solubility agent or the low solubility? If you flip that, you want to choose a low solubility, because think of it this way: if a low solubility has a quick recover or quick induction, quick recovery, then during anesthesia you can make quick changes. Like if I have a patient and I go from 2% to 1%, like if I change the dial with isoflurane, within about 5 minutes you're going to see changes. I mean, it could be less, but I get rapid changes when I used. So halothane, it's because I'm this old. I had halothane when I was at Purdue. And when we would turn up and down the vaporizer, it would take a little while for me to see changes in my patient, compared to when we started using isoflurane. When we got isoflurane, I was like, wow, they respond fairly quickly to changes. So again, and recovery is the same thing. Um, yes. So Bethany, yes, if you want to make rapid changes, the lower the solubility. Okay, let me back up for a second. Okay, if I had halothane and isoflurane in a vapor, or if I had these available, but I know that I have kind of a critical patient, so I want a quick induction, and I want to be able to make changes during surgery because I'm worried about my patient. If you use low solubility, because low solubility agents don't get absorbed in the tissue and they don't dissolve, you get quick induction, quick changes, quick recovery. Okay, so the lower the solubility, does that make sense to you, Bethany? So because when you okay, let me put it this way. If I had a patient on isoflurane, okay, and I turn off the vaporizer, the tissues haven't really absorbed any of the iso, right? If I stop giving it, then what's going to happen, it's going to leave the brain quickly. But say the tissues absorbed a bunch of iso, right? Then I got to wait for them to exhale, and I have to wait for the tissues to release. Yes. So the fact that like iso and SIBO remain like intact molecules, they don't get absorbed in plastic and tissues like halothane and methoxy did. Halothane had long induction, long recoveries. And so the other consequences during surgery, if you want to make rapid changes, I mean, sometimes your patient throws you a monkey wrench and all of a sudden heart rate plummets. I was like a couple terms ago, I was helping in surgery, and I had this dog just bottom out during surgery. And I was like, what the heck? And I just turned the vaporizer off because I'm like, I got to get this dog and he did kind of start waking up and huffing and puffing. And I'm not actually sure, that was a very strange case that we had at the school, but because I was using ISO, I could make, with me turning that patient off, within about 2 or 3 minutes, heart rate started coming up, respiration, I ended up having to put him back on gas, but I was like, I got to get him more awake. I don't know what's going on with him right now. So I got to lighten him up. And the low blood gas solubility agents are going to give you that benefit. Okay. So quick induction, quick recovery, quick changes, the lower the solubility. So again, like when Teresa answered the question, when I go to mask a patient, it's not a fun experience. They struggle. Remember I said they go through excitement phase, they're going to go through stage 2. So my goal is, if I said you had a high solubility, low solubility agent, well, I want to go with the low solubility because it's quicker. The patient's going to spend less time on the mask. I'm going to get the effect I want pretty rapidly, right? Okay. The next thing we have to talk about is MAC. And MAC you need to know what it stands for the test. It's minimum alveolar concentration. And this tells me how potent. Okay, so one thing to understand is I may ask you, what does solubility tell me about an agent? That tells me speed of induction and recovery. If I ask you, what does MAC tell me? MAC tells me how potent my agent is. So every agent, and it's on your homework, and I gave you the answers on that summary sheet, but they're in your book. Every agent has a MAC value. I want to say like isoflurane, I think it's around 1.2, 1.3. SIBO is, I think, 2.2 or 2.4. So and I think like halothane, I think is 0.87. So every agent has a MAC value. And I have put it on that sheet. If not, I'll type it out for you. You need to know the definition of MAC. MAC is the amount or percent of agent where 50% of patients will not react to a painful stimulus. Okay, so MAC is the amount of agent or percent where 50% of patients will not react to a stimulus. So let me use isoflurane as an example, which I said I think was 1.2. Okay, or it's 1.2 or 1.3. So for example, if I went in the kennel and I took 10 dogs, okay, and you guys come with me in surgery, okay, and I take 10 dogs and I put them at 1.2% isoflurane. 5 of them, I can pinch their toe and they won't react, and 5 of them will react when I pinch their toe. So do you see how you apply that? It's telling you that a MAC value of 1.2, 50% of patients didn't react to this stimulus. Now, for example, this is giving us an idea of what we need to put our vaporizer at. Okay, so when I talk about MAC, it's like where do I need to set the vaporizer? Where is this going to be? The lower that MAC, the more potent the agent is. Okay, so halothane 0.87, iso's 1.2, SIBO's 2.2 or 2.4. So halothane is more potent, right? It takes less of that drug to achieve that effect, but sevoflurane has the lowest solubility, so it's the quickest induction. Do you see how those are polar opposites? So the main thing to understand, MAC, which is potency, does not equal speed of induction, because sevoflurane is the fastest induction agent we have. And halothane of those 3 would be the slowest. But halothane is the most potent because of MAC. And sevoflurane is the least potent. So, and one of the reasons that the sevoflurane vaporizer goes to 8% is because it has a higher MAC value. That's why you can't use a sevo vaporizer with isoflurane vaporizer, because there's a different percent, a different MAC, a different vapor pressure. So it needs its specific vaporizer so you can deliver it. So it gives you an idea of, and let me say, when they did that testing, those dogs had nothing on board. That was just isoflurane, and I believe they were like pinching a toe. So if I give my patient a pre-med, now say I take those 10 dogs and we give them like ace butorphanol, what do you think that's going to do to my MAC setting if they now have ace and butorphanol on board? Is it going to raise it or lower it?
Lower it?
Yep. So pre-meds are MAC sparing. When you, because those animals, if I take one, let's do it this way. If I take one dog and no pre-meds, no nothing, just mask him with ISO, and then I take another dog and I give him ace butorphanol and I pinch their toe, they're saying you're going to need 1.2% for the dog that has nothing. But if they have a pre-med, you're going to be able to even use a lower amount because they have sedation and analgesia on board. So one thing that I've told you is that, the reason we pre-med is, one thing is anesthetic sparing effect. If you give them a pre-med, you need less other agents than if, again, these drugs don't have analgesia. ISO, SIBO, none of them have analgesia. So if you don't have anything on board, you'd need a higher amount. So some things are like, what are things that lower MAC? So, the lower the MAC, the more potent they are, the lower the setting on the vaporizer. But What are things that alter MAC? Well, age and metabolic activity. Okay, so if they're older or younger, they may not need as like a higher percent of gas. If they're pregnant, if they're obese, if they have kidney, liver disease, and what pre-meds did they get? You know, you guys have seen how potent dextrometor-butorphanol is. I mean, your dogs for radiology are like out. And I think that's what you guys will use in surgery for pre-med. So we're able to, run lower amounts of gas during surgery. So that's a benefit. So there are some notes under here, but let me do this real quick. Let me pull up hold on 2 seconds. Let me pull up this sheet and I'll explain what I put regarding MAC. Come over here. Here we go. Okay, so this isn't the inhalant summary. Hopefully you guys can all see this. I tried to zoom it in. That I'm kind of summarizing the inhalants of the really important information. This was an extra handout. So this is what I'm talking about. Here's the definition of MAC. So it's on the handout that you need to know for the test. And it tells us how potent. Halothane has the lowest, SIBO's the highest. Potency does not equal speed. So for my example is, now in my brain, that doesn't make sense. And if you're sitting there going, what? It takes a little bit to process that, because to me, if something's potent, I'm like, ooh, it must be like real quick. But it just tells me I can use less of it to achieve the same effect, but that's not always better. When I'm talking about inhalants, the big thing for me is, do I have good control of my patient, and can I make rapid changes? That's the benefit in gas anesthesia. So for example, here I did for each agent, this is the MAC in the canine. Why? Now in isoflurane, I want to say in the cat, it's 1.4 or 1.5 MAC. Why would the MAC be higher in a cat than a dog? I mean, dogs are bigger. So why? Go
Is
ahead.
it because they have a faster heart rate?
Which faster metabolism, exactly. So when you guys see MAC values, and you need to know these MAC values for the test, but I'm only having you know the dog. Cat MAC is always higher because of their metabolism. Exactly. So the slower the metabolism, you don't need as much. But for example, let me explain this real quick. This second page, it gives you where to start your patient. So 1 times MAC means light anesthesia. So if in a dog, if isoflurane is 1.2, what's 1 times 1.2? 1.2. So they're telling you if you have a dog on 1.2, it's probably going to be light anesthesia. If you want to run them at surgical anesthesia, you need to be at 1.5 times MAC. Now, what's 1.5 times 1.2? Well, 1 is 1.2. Half of 1.2 is 0.6. So if I add 1.2 and 0.6, that equals 1.8. That was just a fast way to do the math in my head. But if you see, if I need them at surgical, you're probably going to have to run at least 1.8%. Now, if deep anesthesia they're considered deep when they're at 2 times MAC. So 2 times 1.2 is 2.4. So they're saying some patients at percents of 2.4 are going to be considered deep. This applies to every agent. So here's my example right here. Now, when they came up with MAC, remember, these patients had no pre-meds or inductions. So the pre-meds and inductions are going to alter your MAC values. So I have an explanation here that I'll get. I know we're about done. So if you read this, it tells me, where do I start my patient? Well, typically I throw them on 2%. I induce them 2%. I assess. If they're really deep, I turn them down. If I'm adequate, I leave them. If they're moving, I turn them up. And then you're going to go from there. There's always kind of like a target percent. And when you guys are in surgery rotation, if you're with Dr. Ritz or you're with Mrs. Redmond or Dr. Paul, or they're going to be giving you guidance of whether you think. But I do want you, if when I'm in surgery, I look at the student and I go, should I turn them down? Do you think I should turn them up? I mean, you'll be asked that question. If they're light, we probably have to turn them up. If I think my values are trending down, I might want to turn them down. So I would read this whole handout, and my goal is the homework is due Monday. I have to finish talking about the individual agents, but what I'd like to potentially try to do is review Monday and do just a short quiz over just the inhalants, because I don't want to lose Tuesday, because we have to lecture Tuesday and Wednesday, and I think I'm going to talk about vaporizers. Well, let me think on that a minute. Let me think on that a minute, and I'll send you an email. Okay. Do you have any questions?